Hello, everyone. Welcome to week 4. Today, we are going to talk about trauma signs, symptoms, and assessment. So let's get started. On our agenda for today, the first thing we're going to talk about is trauma-informed care. And I'm hoping at this point you have finished reading the SAMHSA document on trauma, the concept of trauma paper. If you haven't, you might want to pause this recording and go finish reading that paper and then come back because I will be talking about some of the things discussed in that paper. We're going to talk about signs and symptoms of trauma and assessment, which of course those two things go together. So a trauma-informed perspective is something that we strive to have in all environments. I would say hopefully across the spectrum of environments that we have, but it's especially important in mental health treatment because we want to understand where our clients are coming from and create an environment that is safe for them to be able to talk about and process their trauma. So some aspects of a trauma-informed perspective and practice is recognizing that trauma is widespread, that trauma has significant impacts, that the signs and symptoms should be recognized and assessed, and that treatment should actively seek to not re-traumatize. And I think that's, something that we can all agree on, and mental health is really important, but we are seeing these concepts applied in other places such as schools and courtrooms and prisons. And I think that being an advocate for this perspective is also one component of being a mental health practitioner, because we do know that trauma often can present as other diagnoses. Trauma can also sometimes lead to folks being in situations where they are facing court action or other consequences of their behaviors that may be traced back to trauma. And so this is just having an understanding that trauma impacts our world broadly. And the more we can have that perspective, the more we can think about, what happened to a person and really try to understand their history. So let's move forward. There are some aspects of trauma-informed care that are kind of held at the highest standard. First, creating a safe environment. This includes the physical space, and for you all, that means the counseling space. So if you are, on telehealth, making sure that you are in a safe and confidential space and your client is as well. But if you're in a physical office, making sure that the client has their needs met as far as safety in that space. That could mean repositioning chairs. It could mean dimming lights or using lamps instead of overhead lights. Oftentimes, depending on the type of trauma, a client may not want their back to the door. So really being mindful of the physical space, the emotional space, and the client's needs, and letting them tell you what they need to feel safe in the space that you are providing. Next is the relationship. Of course, we talk about this at length in counseling, but particularly with trauma, we want our clients to build connection with us so that they will feel our empathy and compassion. We use active listening. We validate their perspectives of their experiences. And you've already learned that perception of threat is one of the main components that leads to a person being traumatized. And so if someone has perceived a threat to the point that they are traumatized and having trauma symptoms, we want to validate that. And it doesn't matter if maybe you've had a similar experience but not had trauma, or somebody who's had a similar experience and they did not react with trauma symptoms. You want to validate the perception of the client. And then last, emotion regulation. I think this is such an important concept, and you started to learn how to do emotion regulation just through reflection of feelings in your skills class. But many folks need help both learning how to regulate their emotions, but first learning how to recognize their emotions, which is where that reflection of feeling comes in. So this is a really important component of trauma symptomology and trauma treatment, because oftentimes, as we talked about last week, that lower part of the brain is really the driver of emotions, and we need to help get the upper part of the brain back online so that they can it can help with emotion regulation. All right, so what are some of the signs and symptoms of trauma? This is an overview of symptoms, but trauma assessment, a formal trauma assessment, which we'll talk about in a few, will cover more of the areas of trauma symptomology, so that you can have a way to sort of check boxes. And so I do think that it's important to look for these in clients that may not have disclosed trauma. However, if you incorporate a trauma assessment into your intake process, you'll check all these boxes before you start treatment so that you can then plan to address the symptoms that are there. So let's start with the foundational presenting symptoms, which are in the middle. And some of these, of course, will overlap and look like other diagnoses or other presenting issues. So you really do have to look for, the commonalities or multiple presenting symptoms to know, okay, I think this is probably a trauma reaction versus I think this is something else. Some of the foundational presenting symptoms do include a deficit in sort of the person's baseline mental functioning. And if you haven't seen this client prior to the trauma, you may not know what the baseline is, so that can be harder to assess without talking to them about it. However, you can listen for that, right? You can listen for them saying, I just don't feel like my brain is working like it used to, or I just don't feel like, I'm able to process things, or I'm able to get my work done, or attend to my home life the way that I used to. So those are some examples. Other presenting symptoms that could occur are psychotic symptoms, self or other harm, mood disturbance, so fluctuating moods, again, that perhaps did not occur to the same extent prior to a trauma occurring. An increase in substance abuse or new substance abuse, and the ability to care for yourself and for others, some new or change over time, and that ability to care for themselves or their family or other people that they're responsible for. So you can, after going through those, you can probably understand how you wouldn't just see one or two of those and say, oh, this is clearly a trauma response, because that could mean other things too. It could point to other diagnoses or other concerns. But when we zoom in on some of these other surrounding symptoms, you will see how these sound much more specific to trauma. So when you're looking for symptoms, you're going to kind of look at the foundational presenting symptoms, but you really want to also zoom in on the trauma-specific symptoms. So the first is intrusive experiences, and this can be nightmares or flashbacks or intrusive thoughts. So essentially the person cannot control these memories kind of flooding them, when it happens, where it happens, and it creates a feeling of intense distress. And those are often related to, specific traumatic events. The second one is avoidance. You can see this both in thought patterns, you can also see it in behaviors. And so, especially if it is a trauma related to a physical location, the person may avoid going back around or near that location. They may avoid people that they associate with that location. And sometimes this can create a lot of concern within a person's life because, let's say something happened to them on the way to work and now they're going out of their way to not follow that same route and adding 30 minutes to their drive to work every day. So you can see how over time those avoidant behaviors could build up to present pretty significant issues. The next is hyperarousal, and this is the feeling of always being on edge. The feeling of like your nervous system is literally never telling you that you're not on alert. And so that could result in sleep issues and also feelings of just constant tension in your body. So you can talk about hyperarousal as a feeling, always feeling on edge, but also somatically through the body, how the body is feeling. Is your body always tense? Do you ever feel like you can relax? Are there times of day or places that you feel more relaxed or less relaxed? So different ways to kind of assess that aspect of it. But hyperarousal is a huge symptom in trauma, and it's a pretty common one across the board. We see that in most, not all, but most clients who are dealing with trauma symptomology. Next, we have dissociation or cognitive emotional disengagement. Dissociation is, of course, that disconnect between mind and body, feeling like you're not in the present, you're not connected to yourself. Talked about that a little last week, so I'm not going to go over it too much again. But I do want to also talk about the cognitive emotional disengagement, which occurs when your thoughts and your feelings just become separate things. So part of our everyday processing of life really does mean that we connect our thoughts to feelings. They're almost intricately connected. We don't even think about it. It just is the way that we function. And so when that disconnects, a person may have thoughts without feeling, and that can be dangerous for multiple reasons, right? They can put themselves in risky situations. It can affect relationships. It can affect attachment. And so looking for that disconnect between thoughts and feelings may also tell you that a person is struggling with trauma symptoms. And then lastly, somatic symptoms, again, in the body. We know that the brain is affected by trauma and the brain controls the rest of the body. So I think that there's no one somatic symptom, but things that are common are like headaches, stomach aches, pain. If the trauma is a very specific trauma, there may be pain in specific areas of the body related to that, which can include a sexual disturbance issue, particularly around assault and rape traumas, which of course makes sense. So I think it's important to note somatic symptomology because many times people may have gone to their doctor for these somatic issues, their primary physician, and the physician could not find anything wrong or the cause of the symptoms. And so psychoeducation can be really helpful and empowering to let clients know you're not imagining this, you're not making it up, your body is doing this as a reaction to the trauma that you experienced. All right. Here are some other symptoms, and these are more process responses that you gain through your observations. And also when you are reflecting, when you're writing your notes, when you are doing case conceptualization on your clients to think about treatment planning and how you are, how the client's progressing and how you're approaching treatment. These are some things to look for. So again, this may not be something that you specifically ask the client about, though you could, but it also will most likely be things that information that you glean through your observations. So the first is activation. How reactive is the client to the traumatic material? This would be, under the assumption that there's a trauma, that you are talking about the trauma and processing it. How much are they avoiding it, which kind of means they are underactivating. And this could include things like emotional numbing, dissociation, thought suppression, denial, and effortful avoidance, which I talked about a little bit on the last slide. So all of those are keys to, a type of avoidance and underactivation. You also have overactivation, which is more of a flooding. It may be from triggers or other things that can happen, which of course would be something that I think the client would be able to identify as well as you through your observations. Next, we have affect dysregulation. So this could look like intense mood swings, short or intense bouts of depression without, any other identifiable cause. Sudden emotional distress where the client cannot calm themselves. And then extreme tension reduction behavior. So, again, just sort of going out of their way to take risks unnecessarily to try to reduce the tension that they feel in their body. This could look like substance abuse. It could look like other risky sexual behaviors and things like that. And then also dissociation during strong emotions. This is certainly something you could see in a session if you see a person disconnect and not interact with you during a strong emotional processing time, it's likely that they have dissociated. And then finally, relational or contextual disturbance. We know from our brain discussion that when a trauma occurs, one of the things that happens is the inability for the brain to contextualize information. And so this results in things like hypervigilance, abandonment fears, elevated interpersonal control, so trying to control the relationships that they are in, really just as a form of self-protection. And we hope that these things can be addressed through their ability to be in a therapeutic relationship, to teach them about boundaries and trust and safety, and kind of reestablish some baselines around relational and contextual factors. All right. So now we're going to talk about trauma assessment, which of course, really we've been talking about as we talk about symptoms, because as you look for symptoms, as you listen for symptoms, as you observe, you are doing informal assessment. So we've already started talking about this. I do think that trauma assessment should be a part of all of your intake sessions. There are intake forms that include trauma histories. I think those are really helpful. Even if a presenting concern does not seem to be a traumatic incident, there's often a trauma history that can be connected to, disturbances in thoughts or maladaptive coping mechanisms. So if you include a trauma assessment in your intake sessions, you'll know about this on the front end most times. I mean, not all the time, because sometimes clients won't disclose things until they're a few sessions in and they feel more comfortable with you. So in the initial assessment, particularly if you know the client is dealing with a trauma, you want to assess for imminent danger, which we talked about. Is the client suicidal? Are they incapacitated? Are they a danger to others or in an unsafe situation? Go back to your, assessments that you would use for this that we've already talked about in previous weeks, to kind of use what would be the best fit if you do think that the client may be in some sort of imminent danger. Next, you want to look at their psychological stability. Are they in crisis or in shock? And do you need to go to crisis stabilization mode, which you know how to do because we've covered that as well. And that would come before trauma treatment. The client does need to be fairly stable before they are in treatment for their trauma symptoms. How activated are they? Are they able to, stay in the present in the session? Are they able to, participate in the therapy session? You want to assess their trauma exposure, which we'll talk about next, and you want to assess for the effects of the trauma. All right. So assessing for trauma exposure is about talking to the client about what has happened to them. In my history in working with kids who came into the Child Advocacy Center, I knew that they were there because something happened. And so if you're working in a trauma-specific setting, your default may be to always assess for trauma exposure because they're there because something has happened. However, you may have clients who you're treating for other reasons, and then one day they come in and they disclose a particularly traumatic event. And then you would want to go into this mode of assessment so that you can see what the impact of the trauma is on their life, whether it's, in the far past or the near past or even the present. And then also their symptomology to help you plan treatment. So we want to be relational and establish rapport first. You don't want to jump in asking hard questions before they even know you. We want to view people holistically, let them describe their presenting concerns in their own words, but also allow them and let clients know that we are going to ask hard questions. And we know that it's hard to answer those with somebody that you don't know very well. However, it's really important so that we can prioritize treatment. So I'm going to go over to the graphic here and talk about what to ask about trauma exposure. You want to use the funnel technique of questioning, which I think you probably learned in 530. So big questions, broad questions, open questions at the top of the funnel, leading down into more direct, specific questions. And you want to cover questions about severity of trauma, the frequency of trauma, the duration, and the perceived level of threat. And all of these will tell you more about, how the perception of the trauma is impacting the client. Severity, once again, we leave that up to the perception of the client as to how severe it is. If someone has dealt with child abuse, maybe their whole life, their partner hitting them may not feel severe to them. It may feel severe to us, but it may not feel severe to them. Frequency is really important because that will tell you if it's acute trauma or chronic trauma. And that also may have to do with severity and normalization of the trauma or trauma responses. And then duration, does it go on for long periods of time? Is it short periods of time? And how threatened do they feel? And while you are asking those questions, it is really important to use real words to describe the trauma. So please don't make up words. Please don't use words from, maybe your childhood or words that you feel are safer. We want to use accurate descriptions of words. And we want to normalize that for our clients and let our clients know, what happened to you was rape. He didn't just hurt you, he raped you. And so using those real words, making sure that the client understands that you do need a common vocabulary to talk about those hard topics, but it's also comfortable for you and your client to use those words. And oftentimes it can be quite powerful for a client if you as the counselor will take that step and name the act as what it was, instead of using those sort of cushion words that we tend to use as a culture that make us feel better about not having to talk about hard things. When you are assessing for trauma exposure, there are a couple of tips I have for you. So first, normalize talking about trauma with your clients. It needs to be normal for you so that it feels normal to them. If you appear nervous or anxious or like you don't want to talk about it, they're not going to feel okay talking about it. And it's your literal job to help them process what has happened and lead them through treatment for their trauma. So do whatever you need to do to feel okay about talking about these hard topics. That could be seeking your own counseling. It could be practicing with, more challenging case studies. And I'm happy to talk to anyone about that if that's something that you struggle with. Second, be aware of and control of your reactions. If you are a person who has a hard time controlling your body language or your facial expressions or your voice tone, those are things that you need to work on now before you sit with a client and potentially harm them by reacting. Your body language should say, I'm here for you, I support you, sharing is hard, but I am a safe person. It should not say things like, I'm horrified, I don't know how to deal with this, I'm overwhelmed. So even if you're feeling those things, and I think we all do at times, it's really important to try to not stay neutral. I think it's perfectly fine to show a client that you are sad and you agree that it was unjust what happened to them. So you don't have to be neutral, but you do need to stay aware of your reactions and particularly your facial expression, and be supportive. So you don't want to go into a place where the client is having to think about taking care of you instead of you taking care of them. You want to validate their feelings and reactions. They may not have gotten this from others in their life, especially if folks don't understand that their perception of the threat was very severe, or if people think they should have just gotten over it by this time. They need to be validated. They need to feel, justified. And I think that's why psychoeducation is so important. And that's actually what we'll talk about first when we start talking about treatment. psychoeducation is in and of itself a way to validate what the person is going through, but make sure that you are actively validating feelings and reactions. And finally, if trauma presents when it wasn't originally disclosed, so you're 5 or 6 sessions in with a person and they're like, oh yeah, when I was 10 years old, my uncle took me into a bathroom and raped me, which sometimes clients will do things like that. They don't want to start with the worst thing that has ever happened to them. They maybe want to start with a relational issue or concern about their job, but later will disclose trauma. Go back to the assessment phase. So go back to talking about the things that we just discussed, and kind of build on that. You can use a formal assessment. You could start informally and then build to a formal assessment. But let the client know, like, oh, that sounds like it was a really hard time in your life. And as a child, those types of experiences can have a really significant impact on how we form relationships in the future. So if it's okay with you, I'd like to spend a little more time exploring that and how it impacted you then and may still be impacting you now. And so that's your introduction to go back into assessment mode. Language and consent matter. So just like I just gave you an example of talking about that, here are a couple of other examples about making sure that the client understands what you're asking and why you're asking these questions. If it's okay with you, I'd like to ask you some questions about your past. These are questions I like to ask all my clients to get a better sense of what they have been through or survived in their life. That's a great opening statement for when you're doing initial intake assessments around trauma. So maybe you've done your other intake and now you're moving into trauma intake. This is a really good transition. And then next, sometimes people have experienced things in their past that impacts how they are feeling now. Is it okay if I ask you questions about things that may have happened to you? So once again, you're letting them know what you want to talk about and that you're going to ask some hard questions. Remember that trauma is deeply personal and clients might be afraid of telling you or disclosing some of the things that have happened to them because of fears about stigma, fears about stereotypes, and you may be the first person to ever hear about a client's traumatic experience. So you really want to honor that with active listening, understanding, compassion, empathy, and just know that you can repeat assessments as many times as you need to. Clients often do disclose more as the relationship evolves because they feel safer and closer to you. Here are some sample questions, though we're going to move into formal assessments next, and so that will give you some more structured questions. But if you prefer an informal stance when you are doing your intake assessment, these are some things that you could ask. Do you have bad or frightening nightmares? Do you find you can't get the thought of the experience out of your mind? Do you ever feel like you are watching things that happen to you from the outside? That's a dissociation question. Are there things you can't seem to remember very well or at all? That gets at memory and how the brain is processing it. And so, you can see how these questions kind of get to some of those symptoms. You could write your own questions based on symptoms for, your intake interview. You could find samples online and through other therapy providers. So there are lots of resources out there if you don't want to use a formal assessment, but you still recognize that this is a really important part of the intake process. So we are going to talk about using formal assessment. And there are kind of 2 different types of formal assessment you can use. The first is the structured interview, and then the second is more of a questionnaire. There are a couple of structured interviews that you can use. The first is the CAPS, and that is the Clinician Administered PTSD Scale. This is considered the gold standard for structured interviews, and it has been researched through the VA. It's used often with military-related trauma, but also other trauma. And it looks at, it gives you prompt questions for you to assess both frequency and duration, overall functioning. It has rating scales, and I did put you a link in here and in your Canvas page if you'd like to look at the CAPS. Another option is the ASDI, the Acute Stress Disorder Interview. There are only 19 items in this interview, and it evaluates dissociative, re-experiencing, avoidance, and arousal symptoms. So it does hit on all of the big ones. And then next we have the sides, which is the structured interview for disorders of extreme stress. This is a bigger interview. There are 45 items, but it does look at symptom clusters. So some of the things that we talked about, both in sort of the foundational symptoms, but also the specific trauma symptoms. So that can be a good option for a more in-depth interview assessment. And then if you would rather use maybe a self-report questionnaire, there are a couple of different things that you could do. You could use a general inventory symptoms as the MMPI. I think the third one is about to be released or was recently released. And then you can also use symptom checklists, such as the OQ45, that stands for outcome questionnaire. I think we're on the 45.2 now, or the ORS. Both of those, there's information for you in your Canvas page under the extra resources. And then you can also use more trauma-focused symptom assessments. So the post-traumatic stress diagnostic scale, the Davidson trauma scale, the trauma symptom inventory 2, and the trauma and attachment belief scale are all ones that focus on trauma and trauma symptomology. You can use those in your initial assessment, but I would also encourage you to use any of these, both general or trauma-focused, again, not as a pre-post, but as a pre-test, but then, maybe halfway in between your treatment to see how the client is doing and how they're responding to it. And then you could, of course, use it as you are ending counseling as well as a post-test. But I do think that ongoing assessment is really important so that you can see if symptoms are getting better per your treatment and what you're using as your interventions. And if they're not, you're able to then pivot and try something new or work on something different with the client. Remember, part of trauma-informed care is making sure that we don't re-traumatize the client. And so these regular check-ins with assessments can really help you make sure that you are on the right track with treatment. All right, that's all for this week. Thank you. Here's a cute picture of puppies because this material is hard and I know that it is. And I think we all deserve the reward of having cute puppies at the end of the lecture this week. So feel free to send me any questions, either over email or on the class discussion board. And I will see you all next week.